And IVIG is IgG molecule is we all have that in our body that helps us to protect from infections. When we talk about IVIG, it's a pooled product from many donors of blood donors, and it's purified and put in these bags or bottles to be used for treatment of many different diseases. Because it is obtained from many different patients or blood donors, it has a very wide, vast antibody repertoire for that can help with broad spectrum of infectious agents. And also we all have our antigens in our body that our body produces antibodies through IgG, and this IVIG product has many types of what is called anti-idiotype antibodies that also helps with the immune system to kind of immune modulate that. And the products can come as a liquid or a powder form. And in terms of how it is prepared and how many donors you need, there's some regulations about it that each lot of IVIG should contain at least 10,000 to 50,000 donor blood. And it is purified, and ultimately at the end, one lot of IVIG has 15,000 to 75,000 grams of IgG. And worldwide today, actually for both primary immunodeficiencies and autoimmune diseases, 100 tons of per year of IVIG has been used. It's a very maybe long or cumbersome process, many steps, which I'm not going to go through. I probably wouldn't know all the details, but just the general idea how it's prepared. Eventually, when the IVIG is purified from the plasma, the blood, 90% should be IgG molecule. That means that there are some impurities in it. It means that there are some other proteins that comes from blood of the donors that could include coagulation factors, some complement proteins that also can have some immune-related molecules, which I'm mentioning because they are, even though they are in small quantities, sometimes can be an issue, clinically significant. And these steps, it goes through multiple steps, try to eliminate many other proteins in the body that's not needed, and to have this pure IVIG, the IgG molecule in a tube. The steps that, sorry, okay, that it's called fractionation. That the fraction 2 in in this immunoglobulin, the blood, is called IgG, and then it goes through many purification steps that you need to remove if there's any viral particles, and then it has to be stabilized so that it can stay in the bottle. There are many different products available. This is not for you to read. It's just that this is a list of the products that you can find. But that means that the preparation steps may affect how this product is effective. Like there may be differences between the products. The efficacy can be affected from geographical location of plasma donors and also variations in the processing of the product. That causes, so they are not identical, and the volumes would be different. The stabilizing agents that they use to keep it long-term on the shelf could be different. The salt content could be different. The thickness of the IVIG could be different, or the IgA content, which will come later on why we talk about that. So it's mentioned they are not identical, and there are some other issues that came up with IVIG in the past of it, like for example, sugars are used to stabilize it. Now more and more, what do you call amino acids have been used to stabilize the product. There are ups and downs, or the pluses and minuses for each of them. Sugars are better in terms of the IgG molecule, what they call dimerization, meaning that two IgG molecules, when they get together, they can they can precipitate, meaning that it can cause clogging of things. So sugars were better for that purpose compared to amino acids. But sugars also was the problem that could cause kidney dysfunction, and also especially with diabetes patients, it could cause changes in the glucose level erratically. That could have been a problem. So more recently, they also worked on this amino acid products that made the IVIG more they decreased the pH of the molecule and the product, and this precipitation is not happening as much. But we actually experienced this in our practice for the last 5-6 years, maybe a little longer. We are seeing more of anemia with IVIG, which has happened in the past, which is not a long-term or really any, it's not a problem at all. Sometimes patients need blood transfusion for that, but we may be seeing that a bit more often with the new products now. And as mentioned, disease transmission is important. That's why there are some steps. Actually, there are principles that the IVIG producers need to follow. That is to do with screening the donors, and also for the infections. When they get the plasma, that's also screened before putting into pooling together all of them. And also there are some methods are used, almost really truly detergent washes and filtering to inactivate or get rid of the viruses. With that, actually lately since 1990s, there has not been any case of infection passing through IVIG. This is not to, I'm not going to read all this, but this is the mechanism of IVIG being studied by many scientists, still going on, and it is not all of them are very clear or proven, but I'm just going to skip these slides just to show you that there are many literature out there to tell us how IVIG might be working in the body to help with many types of diseases. This is again, it's a timeline of showing each decade there is a new idea that came up about how IVIG might be working to treat our diseases. But I just wanted to summarize here that IVIG maybe seems to be targeting each and every arm of the immune system by causing enhancement of the immune regulators and also inhibiting inflammatory cells. That's why the indications for IVIG is quite wide. There are some people who are born with immunodeficiency, which means they don't have this IgG molecule in their body. So for those patients, all their life, they need to replace by using IVIG therapy. In our world, in autoimmune diseases like the juvenile dermatomyositis or inflammatory myopathies, we use IVIG as immunomodulatory or anti-inflammatory therapy. IVIG can also be used to treat certain infections to help, such as varicella or chickenpox. When you get it, you can use what is called hyperimmune specific varicella IgG. So this is just a list of FDA-approved indications of IVIG, but there's also in autoimmune conditions, again, I'm not going to read all of this, but many types of autoimmune conditions IVIG tried. And by what is called evidence-based approach, these are categorized as definitely beneficial, probably beneficial, which dermatomyositis is under that, including juvenile dermatomyositis, and all may provide benefit, and some are unlikely to be beneficial. And this is the categorization that just scientists use to do. So a little bit about Subcu-IG. It is also in recent years, subcutaneous giving the IgG molecule under the skin was also being getting attention, and has been more and more used, especially for replacement therapy. And it is just like insulin. People do insulin under the skin. This is how it's also used. The same places can be used. just to go over a little bit, and how this has become possible to do IVIG is through infusion pumps. Once the infusion pumps are created and used, it made it possible to use to give IVIG through subcutaneous route. And this is just different models of pumps. And this is a picture of a catheter inserter. And then this is how it looks when you insert a needle and use it. So the issue with sub-Q IG in autoimmune diseases or dermatomyositis is because we use higher doses than patients who use for immune deficiencies. They use replacement dose, which is almost more than double amount we need to use. So it was difficult to give the amount through under the skin because there's not enough room as you would have in your vein. But now there is what is called facilitated sub-Q IG has been used more recent years. I'm just going to say this word once because I am having a hard time to say, but this is they put this enzyme called hyaluronidase. So it made it, I'm sorry, it's very difficult, but it's an enzyme, it's a matrix. In ours, under the skin, we have this fat tissue and what's called collagen tissue, and that is where this small matrix protein is. And this enzyme just melts this protein away so that it opens up a space pretty much. Basically, that's how it is used. So I'm going to call this this is what's called facilitated sub-Q IG. And that actually allowed people to be able to give more amount in less number of sites on the body and in less number of times, less often, like similar to IVIG pretty much. This is just like comparing different types of IgG, how it's given, IVIG, facilitated sub-Q IG and sub-Q IG. As you can see, you can choose just the 1 to 2 size similar to IVIG with facilitated sub-Q and give the same amount pretty much monthly as opposed to the more often sub-Q, regular sub-Q injections. There is also how it works in the bodies. There are differences. That's why these needs to be studied better, because we need to understand if giving IVIG, it peaks your amount in your blood very quickly and it goes down. So sometimes it shoots all the way down, maybe not very desired levels. But sub-Q, if you give it, can stay around the same levels, that may be more beneficial. But both seems to have benefits to it. Or the ups and downs to it. And in terms of side effects, the IVIG and sub-QIG, the sub-QIG has less systemic issues such as fevers or headaches or muscle aches and so on, but the more local injection site reactions with like redness or swelling can happen. But generally both are really well tolerated. And one thing that they also show, that I see this with other sub-Q injection medications, that over time the injection reactions actually improves. It doesn't get worse. So just to go over the pluses and minuses of IVIG, you can give large amounts and less frequently, which is a plus for IVIG. And maybe, as I mentioned, giving a high dose at just once, that may be helping some immune reactions to work better for that particular disease that we are dealing with. But you need an intravenous access. You can't do it yourself, and some reactions happen. You need pre-medications with IVIG, and it is a high cost. For sub-QIG is you don't need an IV. You can do that yourself at home, and there's even serum levels you obtain with sub-Q, and maybe less systemic side effects. And you don't need pre-medication majority of the times. And again, with this new facilitated sub-Q form, you may be able to match that with almost like IVIG. And they did a survey among patients recently in primary immunodeficiency patients that they found 80 to 100% actually prefer sub-Q, which I'm curious about hearing from you all about that. This is just the same comparison. There's a lot of guidelines out there. This is, again, not to read all of it, to say that there's some practical considerations about using, which I think during question and answer, we can go over them a little bit. This is just the graph of showing the likelihood of reactions. Some are very rare, some can be severe though, but generally well tolerated IVIG. I'm just going to skip these two. Again, it just goes over the same kind of, and we can again discuss during discussion. I just wanted to highlight here that IgG therapy is used for dermatomyositis, juvenile dermatomyositis, other myopathies, and it is now considered second-line treatment option for severe disease when you have steroid-resistant or dependent disease, predominantly skin disease, or you have severe weakness and swallowing difficulty. And in children, actually, it is through CARA with we consider it can be used as primary first-line treatment option as well. And there are some case series publications about IVIG to use in juvenile dermatomyositis. This is the early studies on dermatomyositis showing a good response when majority of them really showed good response. This is very recently, there are a case series of like 5 or 6 patients that used Subcutaneous for juvenile dermatomyositis when they are intolerant to IVIG because of either IV access issue or some side effects. And it seems clinically effective. Just some more studies about that. And then again, there's not that many trials, unfortunately, not because it's a rare disease, especially JDM, even dermatomyositis. There are only 2 randomized controlled trials for adults, not any for kids. That's why it's difficult to study this. These are all the published studies. Most of them are really one case report of patients who used IV or Subcutaneous. So just to summarize, it is that we should all know that IgG therapy is not approved in JDMS, but often used, and it's definitely beneficial, with the caveat that no randomized trials are existing. And adverse effects are common, about 30 to 50%, depends on the study, but they are mostly mild and manageable. The factors that seem to cause these side effects or adverse effects are mostly related to the rate of the IVIG, IgA content in the product. Hydration is very important. So that's one thing that I tell my patients, that you need to be very hydrated before coming to get your IVIG. And if you have an intercurrent illness, sometimes it can be a problem. And also the older adult patients seem to have more side effects than children. Thank you so much.
So first I want to talk about health insurance. So, and along with health insurance, everybody needs to be their own advocates when we're dealing with health insurance. So one of my best recommendations can be with your health insurance is to request a caseworker through your insurance company, especially when you're dealing with your child. Send a picture of your child so you're not calling that 1-800 number. You have a person's name and you can talk to that person as you're navigating the different issues with your insurance. You need to understand what's in your health insurance plan and how to choose that right plan for your needs. Understanding prior authorizations, and really at this point, anybody who says that you don't need a prior authorization for immunoglobulin therapy, it's most likely not true. I would get a prior authorization done so that you're not caught up with a massive bill that you weren't expecting. Sometimes you have to go through step therapy. I'm not seeing that as much with children. And you may have to go through the appeals process, but most times we're going to get it on the first time if we do it right. Understanding your out-of-pocket costs. The worst phone call that I get from families is about medical debt, and it's horrible. you need to get a quote so that you know what your out-of-pocket costs are. And if it's unaffordable, then you need to find a way to make sure that it is affordable. You should be able to get whatever therapy you need in multiple sites of care. So if your insurance company does not allow you to get infused in the children's hospital, but allows you in another infusion center, then that may be your option. If they don't allow you in any hospital or physician's office and they only do home care, then you may want to talk with your doctor about at least doing your first infusion at the hospital to make sure everything goes right. And then you can transition home again if your doctor feels it's safe and working with your insurance company. Open season comes up every year. And the worst thing I hear about is people thinking that their plan is going to be the same as last year. And there's changes, and all of a sudden they're caught off guard. So you've got to read that plan. If you don't want to read it, you can contact me. I'm more than happy to look at the plan and help decipher what's in it and what's good, what's bad, and what we need to deal with. Understanding where your benefit is covered. Is it covered under the medical side of your benefits or on the drug side of your benefits? Makes a difference. And sometimes it could be billed in both sites, but it could be billed in a better way under one part of your health insurance than the other. And then your high deductible plans, how you address those, and understanding your out-of-pocket maximums, which you'll hit pretty quickly if everything's done properly. There are places to get assistance, which we keep up to date on where you can go. And you can talk to the hospital about getting some kind of assistance, or you can speak to your specialty pharmacy. If any side of care says that they can't work with you, it's not the right side of care. There's lots of competition out there. So I want to say that you can get the help you need. So if you decide to go into getting your immunoglobulin therapy in the home, what happens is that your physician's office will contact a home infusion center to talk about requesting it for juvenile myositis. They'll submit the request to a specialty pharmacy, and the specialty pharmacy will request your the patient's history, demographics, and insurance information. Then the pharmacist takes control and really looks at the patient's history and disease, and they will make a recommendation for the brand of IG that's best for the patient if your physician hasn't selected a specific brand. As Dr. D showed, there are so many different brands out there, both for IV and subcutaneous. And what's really great news, and I can't wait for Huub to share with you, is that we now have an indication for dermatomyositis for Octagam. So that's a big change for this disease community. The pharmacists will also provide all the necessary supplies and PPE for the nursing staff. So everybody will be taken care of. This, I think, is really important to understand because there's been times where I've had families contact me and say that they want to go into the home, but their doctor doesn't want the child to be seen at the home and get their immunoglobulin treatments. And many times it's because that the physician feels, and I completely understand it, that they're not going to get the personalized treatment that you get in a children's hospital where you're seeing both the doctor, the nurses, social workers, and it's like a whole community and attention for your child. But if you don't have a children's hospital near you, or it's very far, or you can't take time off of work, home infusion could be an option. But you need to make sure that it's the right option for you. So you need to make sure that the nurse understands how to administer IG. And we do have a national association called the Immunoglobulin National Society, which certifies nurses in the administration of immunoglobulin and also certifies our pharmacists. They definitely need to have a nurse for your child that specializes in pediatric or neonatal nursing. They need to use clinical judgment. They need to be knowledgeable about myositis. They need to know all the different ports and PIC access, D-access, and maintenance. And they need to know how to monitor the patient for adverse drug reactions and to administer anaphylactic medications, monitor and manage the patient inventive and adverse reactions. So you will be set up with everything there. The nurse will be with you at all times, and you'll have all the equipment necessary in case there is a reaction. Now, I have a slide for do's and don'ts because it's really important, especially in the day now where we're dealing with COVID. We want to make sure that nurses wear the personal protective equipment and are screened by their company to ensure safety for the patient and family members and the nurse's safety. And the patients are screened to ensure they don't have COVID-19 before getting infused. The pharmacy needs to pack medicine supplies while wearing PPE, and patients can request specialty pharmacies to supply masks, hand sanitizer, and other necessary items to ensure safety. And really, at this point, you can request that their nurse has been vaccinated or find out if your nurse has been vaccinated for COVID, for flu, or anything else that's going to put your child at jeopardy. The don'ts, which is really important. Never is it okay for a nurse to start an infusion and leave the patient for any time during their infusion. That nurse has to have eyes on you at all times. The nurse cannot train a patient or family member on self-infusion of IG for peripheral and ports. They can definitely teach for subcutaneous, but they cannot teach for IVIG. The nurses cannot tell family members to call them on their phone when a problem occurs and they sit in their car during an infusion. They have got to be in the same room. The nurse has to be suited up with all the protective gear, proper protective gear, mask, gloves, shoe coverings. And they cannot require patients' family members to leave the house during the infusion. So those are all really important points. At this point, I wanted just to say, I want to give you my contact information, and I want to say this, and I mean this with all my heart. You do not need to be a patient of CSI Pharmacy for me to be your patient advocate. I'm here to help the CureJM family. So if you have questions, I'm here to help you no matter what side of care you're in, whatever insurance you have. You do not have to come into my pharmacy for me to help you.
So I'm seeing one question in the chat, and she was happy to hear that people are able to request a nurse who is vaccinated. And she's wondering if that's allowed in her area, and not all nurses are. So I'm wondering if there's any guidance perhaps from you, Michelle, about how a family could approach that topic.
So if it's for home infusion, I would call the pharmacy and request it. I know that we're surveying all of our nurses at this point, and if a patient asks to only be infused by somebody who's vaccinated, we are going to do that. And right now, there's a lot of changes occurring quickly in terms of more vaccinations going on in the workplace. And if you're contracted with Medicare, you're going to need to. So I would say that all of these entities are going to be vaccinated if they're not already.
I'm back. Can you hear me now?
Yes, we can hear you now.
I could hear you, but you couldn't hear me for some reason. I'm so sorry.
All right. Well, Dr. Kreuwel, welcome, and looking forward to your update on the work of Octapharma in our area.
Sure. Sorry. Apologies for the technical issues. We're very pleased to announce that we finished a very large phase 3 double-blinded randomized controlled trial. That was done in adult dermatomyositis. It happened all over the world, both in the US, Canada, as well as Europe. We filed the data with the FDA almost a year ago, and the FDA has agreed that indeed this could lead to an indication. So currently our Octagam 10%, which is an IVIG product, has now an FDA approval. We presented the data already at major conferences, and we have some more work at a large rheumatology conference called ACR. So we're very pleased that we were able to reproduce the original data from Dr. Delakas. And we have now an indication. So I think that will certainly help with patients and insurance issues. So that's kind of my update. I can go into more detail on that trial if you want, but basically it was the classical standard treatment of once every 3 to 4 weeks with 2 grams per kilogram body weight. And we measured total improvement score, which is a score that a lot of rheumatologists and neurologists use to measure whether a patient indeed is responding well to IVIG.
Dr. Kreuwel, I have a question, a two-part question.
Sure.
Number one, you had mentioned that you thought the approval of Octagam might assist with the future approvals for insurance coverage. I guess number one, sort of how so? Why do you think that might be the case? And then the second part of the question is how that might apply to juvenile myositis for a disease that at this point is not approved. Your product is not approved by the FDA.
Yeah, maybe Michelle can speak to that better than I can because she deals a lot with insurance issues. But all I can add is now we have a very large trial that is now positive. There's sometimes pushback on, that the original finding was not in a large enough trial, or, an insurance company could still say, it's not FDA approved, meaning it's off-label. It didn't always happen, but sometimes that does happen. So I do think with this data, I do think it should help with insurance issues. Michelle, maybe you can add to that.
Sure. No, it definitely will help with insurance. So once you get an FDA approved indication, it changes things dramatically. So when you see insurance companies saying that they consider it experimental, it's not, or it's off-label, it's not. And so that really changes the game for everything. It also leads to a lot of times the studies that we may use for insurance purposes, and I'm going to use subcutaneous, for example, there aren't many studies for juvenile dermatomyositis, but there are for dermatomyositis. So when we get cases where family members want to switch to subQ and the doctor is definitely on board for that, we definitely have to do a prior authorization, a letter of medical necessity, and we put journal articles together with it. And we'll use the adult cases for the juvenile. And insurance will then look at that, and a lot of times they will cover it. So it just starts changing the game for this disease group.
Other questions?
There are 2 questions in the chat, so I'll start with the first. Is IVIG good for a patient who is positive for skin and calcium buildup of dermatomyositis, but not the muscle weakness antibody. Perhaps Dr. D could.
Yeah, absolutely. I mean, as IVIG is, it could be very effective for skin-only disease. Actually, that's one of the like we use it as a first line IVIG, and you know, for if there's calcinosis and so on too. So there are some. Calcinosis is a very difficult thing. There's no good any medicine that works well, but there are certainly IVIG that it's helpful. That calcinosis seem to get worse after, for example, stopping IVIG, that you have to restart and so on. We certainly use it quite often in patients who have skin disease.
Thank you so much. And the second question posed in the chat, they had no idea sub-Q was an option for IVIG. When is it indicated?
So at least from my perspective, the patients who a lot of times come to us are people who are having a lot of headaches, you know, a lot of side effects. They may have venous access issues. And then there's another group, which I find really fascinating, is the kids who are either going to college and their schedules, or they're in or even, you know, high school or elementary school, where their schedules are just really packed with stuff. And it just, the families want to look at that. And it's something that the doctor has to make a decision. Is this the right course of treatment? Dr. D, do you want to add something to it?
Yeah, I must say, you know, I am still not, I'm a little bit hesitant to suggest sub-Q. First of all, when I was preparing for tonight, I read a lot about, and I wasn't aware of this facilitated IVIG sub-Q. So like that you can give larger doses. So that's an issue with this sub-Q because we use higher doses, so you need more sites. And if there's a 3-year-old child, it's very hard to get 4 or 5 sites every week. So that's why it has been difficult. I still have to, I think, need to understand what this you know, like melting away this matrix protein, is it safe enough, and so on. I would feel a little hesitant still to use it, but as you said, like older patients, when they have they go to college and so on, that's definitely something to consider. I must say, there's always a way to deal with the side effects of IVIG. I have, like, very rarely that I've come to a point that I cannot use IVIG. There's many options to do, like pre-medications, the using steroids or hydration, and slowing down the rate has almost always worked. So I don't have a lot of patients that had issues with IVIG.
I mean, I can say that for the regular subcutaneous products that are, you know, you're talking about 20% concentration versus 10%, that I've treated, you know, I've worked with families with children as young as 5 years old, JDM families, and we're talking about 2 sites, not 4 or 5 or 6 sites. It's 2 sites once a week. You're talking about using numbing cream so that you don't feel the needles in, and you will get little welts. But once they go to sleep, the next morning, those welts disappear. And so they seem to do really well with it. Again, it's a personal choice, and it's a choice to work with the physician. And in those cases, some of these families, they just weighed the pros and cons of the problems that they had with the IV product, and they did really, really well with sub-Q. So it's just nice to have choices, and there'll be more choices as we move forward.
I mean, I think I also have maybe, like, you know, the mechanism that we don't understand it very well. There might be, it's still going to be like understanding the disease and individualize, because giving IVIG, like a burst of it, it might be like the pulse dose steroids we use and also daily steroids. I'm almost looking at it that way. Pulse dose has different advantages, especially at the beginning of a disease. So there might be benefit of giving IVIG in certain situation to actually be more effective for the disease. Fortunately, without having good, the kind of trials and so on, it's going to be difficult to do these. But because one of the mechanism of IVIG, you need a big dose so that you can saturate this certain receptors and so on. So that depends on what mechanism is used for that particular patient.
Yeah, no, I mean, the physicians who have treated with it, they do the IV dose and then they go to sub-Q. So you're at that peak and then you're seeing it level off, so that you're not dropping at all. But I completely understand. And we need to do case studies on these, on all the children that have been on subcutaneous until we get a trial. At least the case studies will tell us what's going on.
I have another question for Dr. D. How do physicians typically determine what product to use, what brand? You had mentioned, and we all know there's like a fairly large number of brands out there, and my understanding anyway is they differ somewhat from each other. But how do physicians go about determining which is the most appropriate brand to use for any particular patient? Is it by age? Is it by other data information that you have on the severity of a child's case?
I think the brand wise, like it depends if they're giving it in the hospital, usually whatever the hospital brand is. Sometimes insurance dictates too, like they say that this is what we approve, which is okay. I don't usually have a particular way of like this brand is or that brand, but like it depends. If we see reactions, that's usually changing the brand. Sometimes I try other things before first, like the pre-medication or hydration, all that. Try not to change brands if until like if that's not working, then I change it. But I don't have a particular I mean, when I read about things like IgA content seems to be less of a problem now. That seems, since there was one study showing that IgA content could be an issue. So you may want to choose the lower IgA content brand.
Yeah, maybe to add to that, the IgA content is mostly important for PID patients who are deficient and have a reaction to the IgA. But typically for DM patients or CIDP patients, the IgA content is usually not that critical. But the difference is sometimes in products, at least from manufacturing standpoint, we all fractionate a little different, and therefore sometimes that have consequences. And then what Dr. D already mentioned, the stabilizer. Some people don't do well on a certain stabilizer or not, and then you can do pre-medication, or if worse comes to worse, you can switch products. Sometimes that's not easy to predict whether a patient will respond to a stabilizer, but certainly you could always ask your physician or a pharmacist to switch. Typically, pharmacy usually have access to multiple products just in case that happens and they have a patient that is not responding well.
Also, we often have shortages. Unfortunately, when there's a shortage, like you get stuck with one, whatever is available.
Claire, I think I saw another question come across the chat.
Yes, so the question for Dr. D, how do you determine how often a child should receive IVIG?
Yeah, it is depends on the disease, how active the disease is. Generally, we start, the recommendation is giving 1 gram per kilogram 2 days in a row every month. In my practice, we usually give it every 2 weeks. That's another, but the same, it's a monthly dose will be the same. That's how we start, 1 gram per kilogram every 2 weeks. I like that because, again, the higher the dose, the more likely you will have reactions. Like if you give 2 days in a row, I've seen more of reactions happening, or there are some, they give this full dose in one time, like Kawasaki disease patients. But again, I prefer to do 1 gram per kilogram every 2 weeks for at least 6 to 9 months. And then we try to space if everything is going okay, muscle testing, clinically. Sometimes we do, the blood test is going to be okay. If we are not sure, like younger kids, sometimes muscle exams are not very easy to make sure that everything is controlled. We do a repeat MRI of the muscles, making sure there's no inflammation. Then we try to space out every 3 weeks, every 4 weeks, that gradually do decrease the frequency.
All right, do we have any additional questions? All right, well, Dr. Kreuwel, Dr. Dedeoglu, Ms. Vogel, thank you very much for your extraordinary presentations. I know this was quite an enlightening education for me. For those of you who have any questions, I know our presenters will be available by email. Just get in touch either with me or Claire, or Michelle certainly put her information up for all of you. This presentation will also be available on our YouTube channel and on our website within the next couple of days if you want to spend any time reviewing any of those slides in particular. So thank you again for your extraordinary presentations and for being with us. We're very appreciative, and thanks for all you do for all of our CureJM families in helping us bring these kinds of programs to you. We'll talk to all of you again soon, and thanks, and enjoy the rest of your Sunday.